Good morning, everyone back in Canada. My name's Mike Christian. I'm a doctor with a background in intensive care and as well as infectious disease and public health, living here actually in London, England at the moment. Chatting to you from sunny London. But my background was spent largely in Toronto and Ontario. I've also spent the last 20 years or so working in emergency preparedness, disaster management, and outbreaks, starting really back with the SARS outbreak a number of years ago, which I was on the front lines during the first wave, and then the investigation team in the second wave, and then after that was invited to be on the government ministers task force that designed and redeveloped the public health system in Ontario afterwards, and on the executive of the founding board of the Public Health Agency, now Public Health Ontario. So I have a long background in this, and the reason I'm actually here today and that I've teamed up with Scott on this topic in particular, but in general in emergency preparedness, is because after 20 years of developing 4 different international guidelines, as well as a lot of work advising governments around the world, one of the things that certainly has struck me is the challenge of bringing guidelines and this high-level advice to the front lines and to reality. And that's one of the things after meeting Scott that he does exceptionally well in terms of what he calls operationalizing these guidelines and making it real. So Scott, why don't you tell us a little bit about yourself?
Hi, welcome everyone. My name is Scott Ashley and I'm the co-founder of Get Ready. For years I worked as a paramedic down in Los Angeles and Toronto, and on Bandage 1 out of Toronto on the air ambulance. And you know, everywhere we went and every story we heard, it always seemed the same. Nobody seemed to know what to do. They thought they could call 911. People would arrive in sort of, you know, great numbers and save the day. And so we started developing specific first aid programs and got into bringing defibrillators and AEDs when they first came out. And ultimately, after 9/11, everyone wanted emergency and evacuation plans. And so we started developing these for, you know, for many of the Fortune 500 type companies, municipalities, and so on. And then when the H5N1 sort of poked its head up, we got a number of healthcare professionals together and developed a program to help really, as Mike said, to operationalize. How do we take all this information from the big public health agencies and actually turn it into a screening station for your workplace, or send a worker home, or what's the actual form they have to fill out? And so now Get Ready has complete sort of cloud-based tools on emergency management and business continuity planning and infectious disease outbreaks and so on. So I'm really excited to be here, and I'm glad we've had such a great turnout. So back to you, Mike.
Thanks, Scott. So I thought today in this sort of 30-minute webinar, what we would cover is first off a little bit of novel coronavirus and outbreak science. That's mostly because I think it's really important for people that are leading this in an organization, whether it's a hospital or an institution or a company, to understand a little bit of the background, and so they have confidence when they speak to their staff and they can comprehend what's happening. We're going to discuss 2 case scenarios, some of which people may be facing where they are now, and hopefully won't face the second one. Then Scott's going to touch on the Get Ready Infectious Disease Outbreak Toolkit for a minute, and we're going to try and save 6 or 8 minutes at the end for questions, which will allow you can type in to the system. All right, so moving on to some of the science, so 6 minutes of science. So novel coronavirus. So coronaviruses in general are a virus that's been known to humans and animals for a long time, circulate quite widely in both animal and human population. They cause everything from the common cold that you have all the time, right through to much more serious illnesses that we've experienced more recently after they've transmitted from animals to humans. First, the SARS back in 2003, and then what we call MERS now, Middle Eastern Respiratory Syndrome, which is quite similar to SARS more recently. Just going to get my laser pointer here. So just for so coronavirus stands for a crown or a halo, and this is the virus. You can see my laser pointer in the top picture, which when we look at it, it's got all these studs on it, but when you get a cross section of this virus, you see this nice crown around it. It looks like a crown of thorns kind of thing. So that's where it gets its name from, for coronavirus. So the coronavirus has a number of different types in this big family of coronaviruses. These 4 types here are the most common that cause the common cold. They come in both alpha and beta divisions of coronavirus. And you can see from the beta division is where we get, the beta lineage is where we get SARS and MERS. And then on the right side, panel B, what you see is this genetic tree and how they link. At the top in blue, SARS, down towards the bottom, MERS, and in red in the middle is that new, what's being called the beta coronavirus Wuhan, or novel coronavirus 2019, which is what's causing our current problems. And you can see it's genetically separate from the others, but a closely related cousin. So moving on to what we're seeing right now in terms of world numbers, and this is just as of yesterday, there are just over 40 some odd thousand cases confirmed globally, about 900 deaths, unfortunately, from that, and cases now spreading in sort of United Kingdom and France through a chain of transmission, as well as some cases in North America, but predominantly still focused largely in China and Asia. So in terms of the symptoms, and this is a paper from the New England Journal of Medicine that talks about sort of average symptoms that were seen in one of the, or some of the first patients. And we see that it's the usual types of things. Fever is present in almost all patients, cough throughout most of the course of their illness, a little bit of a runny nose, some fatigue and tiredness, occasionally some nausea and vomiting and diarrhea, and a little bit of belly pain in some patients as well. So, and this ranges right from, this is sort of the average symptoms. We have some people that have very minimal or no symptoms, and right through to people that get critically ill with breathing problems and lung problems. So everyone asks me right now, well, how bad is it? And what do I think? What do we think is going on? And I think it's important to understand a couple of concepts you might hear tossed around to understand that. The first is the case fatality rate, and the second is the reproductive number. And this is really how we get a sense of how bad things are. So the case fatality rate is what we're going to focus on mostly in the next couple of minutes. Reproductive number, we can talk about a lot more some other time if we have more time, but the reproductive number talks about how transmissible the infection is or how much it's spreading. So if a reproductive number, an R naught, we call it R naught of 1, means that every one case gives it a 1 more. If it's 1 or above, the disease will be maintained in a community. If it's less than 1, the disease will die out and go away. And that's a factor of a whole bunch of things in properties of the infection, of the virus, as well as public health measures. But case fatality rates are really what you're hearing a lot about right now. And the case fatality rate are the total number of deaths over the total number of affected patients. So one of the things that's important to understand is that there's a spectrum of illness. And again, just going to the laser pointer. So what we see is right through to fatal or very mild symptoms, as I was talking about. But these top two blocks, the fatal and the severe, those are the patients that end up in hospital, and often the patients that end up getting tested, particularly in China right now. There's a whole pile of mild or asymptomatic patients out there that may never go to hospital, may never get tested, and the only way we'll actually find out about their illness down the road is something called, we do serosurveillance and test populations to see who had antibodies to that. This is important because it helps us understand that the case fatality rate's probably going to change and likely going to drop. So as the bottom number, then the denominator increases, case fatality rate is going to decrease. So right now, that 900 deaths out of about 40,000 patients is just over 2%, but we anticipate that there's a whole pile of asymptomatic patients in there that aren't being picked up. So that 2% would mean, if it is 2%, that 2 out of every 100 patients that contract the disease are likely to die. So this is a table from another New England Journal publication that was recently put out that sort of compares the case fatality rate to other diseases and illness. And we see here the top line, the new novel coronavirus is unknown, but as I said, probably around sort of of documented cases around 2% now. Say it's even less than that at 1%. But if we compare that to the pandemic H1N1 of 2009, certainly in Britain, it was around 0.02 to 0.001%. So this is about a magnitude of at least 10 to 100 times sort of slightly higher risk of death than what we saw with influenza. We'll talk about in a minute what the difference is. but it is certainly far less than we see with SARS, and we saw with SARS, which is around 9%, and MERS, which is around 34%. This is another publication recently out from the New York Times, just a nice graphic that shows sort of these in comparison. So we're thinking that the case fatality rate, which is on the axis on your left here, which is a logarithmic axis, which is important to note, is somewhere in this sort of pink area, so somewhere around 1% to 2%. And the reproductive number, which is along the axis at the bottom, is somewhere just over 1, probably less than 2 or 3. So this is, and you see a lot of the diseases that are spread by cough and droplets are in this sort of range, and you see measles out here on the far right, which is a truly airborne disease, which spreads at a much higher rate. Now, the difference is in terms of case fatality is really about the total number of patients that are infected, and seasonal flu, which has a case fatality rate somewhere, as I said, this is probably a little bit higher than most would accept, somewhere down here, close to 0.001%. And the difference is the volume of patients that are infected. So on average, 15 to 20% of patients get influenza every year. But with this new virus coming out, technically the entire population is susceptible to it. So if we have large numbers infected, we're more likely to see the situations like we're seeing in China right now, with hospitals really being overflowing and a lot of demand on the system. There is a bit of good news in this, which is, and this is true certainly for coronavirus and influenza, and not every infection and virus, but by and large, as the severity increases, so the virulence, how many people it kills, the higher the case fatality rate, generally the less easily these viruses spread for a variety of reasons. But with this one, where it seems to be more infectious, the chances are the virulence is actually going to be lower, which is a good thing. So moving on to case scenario 1 now. So this is a case scenario about an employee that comes back to your company or your organization, just having had a business trip to China, and we're going to discuss for a minute how to manage that. I'll bring Scott in just a second, but the first question that I often get asked right now is, do travel restrictions help control the spread of infection? And why are they putting travel restrictions on cases? And I think this is very timely at the moment with the discussion we're having in England today, if you're following any of the news on BBC. So we've had a person who was on a business trip to Singapore, was infected there and has just transmitted to 11 patients here in the UK and France, including 2 healthcare workers at his local GP. Now there's a couple of interesting things about both this case and the one presented here, which is that he transmitted most of those viruses when he was completely asymptomatic. And that's what was shown in this New England Journal paper here of this German traveler who had the same thing. He again went to a business meeting in China. Actually, sorry, they had someone visit Germany, was asymptomatic, transmitted infection to a number of people, and particularly if you look at the bottom patient here on the patient number 4, that the contact that this person had with patient number 1 here was all prior to this person having any symptoms, yet the virus was transmitted. So, and that the symptoms can take up to 14 days to occur, which is right now why we're suggesting people who come back from an area with infection quarantine or isolate themselves for 14 days. And that's in a particular situation where we have an area of the world that has a lot of activity of the disease happening in parts of the world that don't really have any. This is really to try and prevent the importation of cases. And all travel restrictions will really do is slow down the spread of it. You can't stop it worldwide by this, but the idea is that this may slow it down in time to 2 things: for summer to come and to get a less favorable environment for transmission, but also to help give us time to prepare, as well as potentially vaccine to be prepared, but that is 6 months to a year off. So Scott, on to you now. So what do you do when this coworker comes back as an organization? What do you have to think about? What do you have to do to address this person and manage this situation?
Yeah, Mike, companies should be thinking about, do we have a travel restriction in the first place? Do we have a quarantine process upon returning from a travel, especially in an area of a known outbreak? What is the ultimate return to work screening process? Do they have a self-screening process in place that workers can do from home before they even decide to come into work? Say, wow, I have a fever, I have a cough, maybe I shouldn't go into work today. If they don't have that, do they have a screening station? And we'll talk a little bit more about that later. But even just reporting in and advising your manager, or have you set up an absence reporting team sort of process that workers can phone in and say that they're going to be absent, or that someone in the organization is actually tracking all of this? You need to get ahead of this and think about this very soon. So as people maybe do start to travel, we have one client we're working with where they put in a travel ban for work, and yet they found that some people were still traveling to locations in China personally. And ultimately, they put in an advisory. They couldn't really ban them, but they strongly encouraged that they not go there, and that they did, in fact, have a quarantine upon their return. And that was a minimum of 14 days.
I think these are sort of two good points there. So one is you have to sort of be documenting, tracking this to begin with, because that's, if you don't do that, you're kind of lost and behind the game. And the second thing is that these are often decisions that aren't the typical decisions that people make on a day-to-day basis on for their business. So do you have any advice that you offer them, or ways that they can help think about weighing and balancing these decisions?
Well, when we look at our program, for example, we base it on the various stages of planning and preparedness and the actual outbreak time. And during the preparedness, we saw this happening before Christmas. Companies start thinking, organizations start thinking about, geez, this is sort of appearing. What should we be thinking about? And you actually have to establish an infectious disease outbreak team who's going to think about this problem for your organization and begin to go through the steps in preparing. You can't wait till suddenly people start phoning in sick and then scrambling, or at least that's not an ideal situation.
Thanks, Scott. And where do you suggest people obtain information from this? How do you sort of direct people to get information, both the company but also the employees? How do how are they to know what to do?
Well, as we know, there's a lot of social media out there around this, and that's not the place to get it. What we need to be doing is the company needs to be checking in daily on a regular basis to the official websites, Public Health Agency of Canada, World Health Organization, and so on. They need to have a communication plan to staff, to contractors, vendors, to customers, and explain what's going on and what steps are being taken so that everyone's aware of what the expectations are upon arrival, or things like a self-screening process, quarantines, and so on.
I think that's very good information. Certainly during SARS, I worked closely with a friend, mentor, colleague of mine, Don Lowe, and he was an excellent communicator and always talked about that what happens in that void that forms if you don't provide information, and how other ways people will find other ways to fill it, and often not the best information. What's the knock-on impact of this for policies and procedures in a company? So what do you do when you have someone stay home for 14 days?
Yeah, well, this is where it gets always a little bit tricky, but a lot of companies will build a policy on keeping someone at home or putting a quarantine in. But the real question is how do you operationalize that, and what kind of procedures? So exactly what do staff need to do? What is the form or the questionnaire they actually need to review on a daily basis before they come to work? What is the phone number or the extension or the email that they need to contact at the workplace to tell them that they're going to be absent? Some of this, and I'm sure many of you have seen this before, but there's two aspects of the absenteeism. One is sickness or quarantine, and the second one is what we call the fear factor. And maybe they're not going to send their kids to school because they're afraid, or another family-related issue, and they're going to stay home anyways, even if they're healthy. So some of this looks at the ability to work from home or telecommuting. These all start to play into how an organization is going to respond and be ready.
That's great, and that's, I think, the situation that a lot of people are sort of facing at the moment. Certainly, know here colleagues in the UK and whatnot, looking at the returning travelers. But the next worry is what happens if we do start to get local chains of transmission. So we move on to that next phase of the pandemic, and the travel restrictions haven't worked. We've got more what we saw in Toronto during SARS and what they're seeing in China at the moment. So I guess one of the things you want to do is try and not let a virus transmit at work and try to minimize that. So how do you help keep set up staff screening and at work there?
So first of all, Mike, I think the big thing is for everyone to think about is goal of a screening station process is to demonstrate to staff, to visitors, to contractors that the workplace is actually safe. And therefore, people who are ill, people who are suspected or quarantined are not coming to work. Some of you may recall back in 2007 and 8 and so on with the H5N1, everyone was saying, well, we'll just buy, thousands and thousands of N95 masks. And that's not going to work. So we need to have a screening process where people can either self-screen at home, but at the actual workplace, people are screened, contractors are screened, visitors, customers are screened, so that if they are identified as having an exposure, that they can be, given a document that they wash their hands. Maybe they're given a mask to go back home or be on public transit. They're advised to seek, their medical professional person, and if they're clear, then they're allowed to come in. So that screening station practice, you have to have staff who are willing to operate that screening station. There has to be signage. There has to be a flow. We want to protect the workers who are talking to new staff or to visitors coming to the site. So maybe they need some PPE or personal protective equipment. There needs to be a log recorded as to who was here, on what date they passed, or the people that didn't pass, so that can be tracked by your absence reporting team. Like the case in the fellow from Germany, if we may have to go back and say, that patient, that worker actually got the virus, and so then they have to go back and look at who might have they been in contact with, with other workers or in meetings and so on. So all of that organizing is really, really important, that it gets done every day and clearly tracked.
Certainly know from SARS, it brings back memories of sitting there contact tracing and being on teleconferences with people we're interviewing and listening to them and hearing my heart sink when they say they went to this place with lots of people, and you're like, oh, so many people to contact. But that can definitely have a huge impact on your operation if you don't have those logs, if you don't know when people were there and not there. Like, if that ability to help public health to be able to trace and be able to say, okay, this is actually the target area we need to think about, and not, it's not everybody at work that now has to be off. It's, it's just this small group that were here and had contact. I think we had covered HR policies in the last one. Is there anything, do you have advice or what you can do to people to think about how they can keep their workplace clean and prevent transmission in the actual environment itself?
So from facilities perspective, maintenance, housekeeping, and so on, there has to be a step surfaces, doorknobs, things like that, obviously. But it's also things like call centers, and the afternoon shift is coming in, and they're going to sit at the same desk that the last person was at. And how do they clean their headsets and their computers and surfaces and so on? Again, we want to make sure that people say, well, I got some stuff, and probably a bunch of ordering supplies right now is tricky. We were talking to one of the medical supply companies, and they were out. A lot of the stuff had been purchased, and they were waiting for the next one. So, what are the options? What are the choices? And so you have to have a clear protocol as to what needs to be cleaned, how often, what type of cleaning solution, and so on.
I see. Yeah, no, certainly. It's I think that also goes back to just the day-to-day business continuity plans and knowing who your vendors are, who your backups are, and stuff like that. Staff communication stuff we touched on last time in the first scenario with communication plans, but I think, for me, a lot of the work I do is around leadership and leaders, and really this is all about, looking after your staff and your people and communicating to them and really taking care of them and your clients. Does that seem fair?
Yeah, absolutely. There's a process, a protocol for communications, and basically when people look at this stuff, your communication structure should be around providing factual information. What is the current status? What are the facts? What's happening? We're activating our screening. We have a local outbreak, so on. Then the reassurance. We have plans. We have procedures. We have process in place. We have training to our staff that they can access. And then it's advisory. So the reassurance is, what we have stuff in place. The advisory is don't do this, be prepared for that, so that people know what to expect. And then what's the next update? When are we going to come up with new information again? So we're not getting lots of phone calls and worry. We're being very clear to our staff. And the other point, Mike, with staff communications, the absence reporting, is the earliest the better. If it can be the day before, 12 hours before, 6 hours before your shift. Because from a business continuity perspective, if one department, for example, had, 2% of their staff off, that would be, a normal day. But what if 10, 20, 30, 40% of those workers in that department weren't available? Now your business continuity plan starts to kick in and you start looking at how you're going to maintain operations. So the communicating both way between staff and the organization and out is really important.
That's great. I want to leave a couple of minutes, or at least to try and get a couple of questions in. So I think, there's a lot of lessons that we've learned. This one thing that drove me crazy for the longest time, went through SARS, H1N1, Ebola, and as well, even back to West Nile. And we keep on learning these lessons again and again and again, but it's really applying them. And I think one of the things you've managed to do is capture a lot of that knowledge. So can you tell us for just a minute, so we can get a question or two in about the IDO program?
Well, we took our experience from over 10 years ago. We have probably somewhere between 150 and 160 pages of pre-drafted policies, procedures, actual checklists that certain staff would have to follow if they were on the screening team or if they were on the absence reporting team. The types of communications we've pre-drafted for all stages of the outbreak, for staff, for vendors, customers. We need to operationalize this, and we've said that word a number of times, but really, if we can help make this simple so organizations, can use the tools, they can literally copy and paste this in, customize it to their own program. We have an online training program for staff. It takes about 20 minutes. Everyone can understand what's going on, what the terminology is. We have tabletop exercises that organizations can test their plan, which are really important that you do that. We have a staff emergency app that they can get rapid information. And I think one of the biggest things is this weekly outbreak reference panel. We ran this a number of years ago, and we had a lot of organizations who wanted to know what was going on and how that impacted and how they could, customize it to make it work for their organization. And so, and the last thing, I guess, is, the certificate of completion. When an organization has trained its staff and tested its plan, we actually issue a certificate of completion, Mike, so that they can show their customers who are asking, are you going to be in the game? Are you ready to go? And so there's a process that they can show that, in fact, they have an infectious disease outbreak program up and running.
Sounds fantastic. Shannon, we have just under 2 minutes. Do we have any burning questions there that we might be able to answer? 30 minutes is definitely way too short for this topic.
so here's a question. I can see. What are the screening questions that you would ask, and how do you respect privacy? So the screening questions have to be fairly simple and achievable for virtually every worker. So the question is, have you been in an area of a known outbreak in the last 14 days? Have you been in contact with people in a known outbreak in the last 14 days? Do you have any of the following signs and symptoms? And now, if you recall, they were trying to take people's temperatures and stuff. Now there's just some ultraviolet scanners that you can actually just get a quick, it's like a little ray gun almost kind of thing, and you can just aim it at their forehead and you can get a temperature off that person. Non-invasive, we're not trying to put thermometers in people's ears and all these kinds of things. So that works out really well, actually.
Okay. Well, just before we lose people, because we have just over 20 seconds left, how can people get in touch with you, Scott?
So if you want to reach out to us, getreadyglobal.com is our website. Scott.ashley@getreadyglobal.com, or contact Mike Minnick, our client support. Mike.Minnick again at Get Ready Global. we'd love to be able to talk to you and help you and make you realize how much time and effort this is going to save you, and hopefully building a plan that everyone has confidence in takes away a lot of the worry.